Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Shahlla Kamal, working as consultant gynecologist in Tertiary Care Hospital. Today I'm going to present a skill demonstration of shoulder dystocia. This delivery of shoulder dystocia is very important for undergraduate, postgraduate medical students, undergraduates for their OSCE examination in final professional, and for the postgraduate for the intermediate module and part 2 examinations. Shoulder dystocia is an obstetrical emergency. How you will define the shoulder dystocia for the newcomers? Shoulder dystocia is the cephalic vaginal delivery where the head has been delivered, which requires extra maneuvers, and the gentle traction for the delivery of the shoulders is unsuccessful. So the head has been delivered, but the shoulders are caught above the pubic symphysis. Its recurrence is about 10 to 15%. This delivery of the shoulder dystocia is high risk for maternal as well as the fetal morbidity. What could be the maternal morbidity? Maternal, there the most important four maternal morbidities are: number one, third and fourth degree perineal tear, cervical and vaginal lacerations, postpartum hemorrhage, and there could be the psychological problems to the mother. For the fetal problem, there could be the brachial plexus injuries or brachial palsy that could be around 2 to 7%, and the fracture of the humerus and the clavicle is 1 to 2%, and the hypoxic brain injury. That is why this is called the obstetrical emergency, and that can end up with the maternal or the fetal morbidities. What would be the risk factors? Risk factors for the shoulder dystocia are macrosomia, uncontrolled gestational diabetes mellitus, as well as the insulin dependent diabetes mellitus, or diabetes mellitus without insulin independent, all the type of diabetes mellitus if they are uncontrolled. Then if there is a patient is obese, markedly obese, a previous history of the macrosomia as well as the previous history of shoulder dystocia, these patients has the high risk or the risk factors for developing the shoulder dystocia in the current pregnancy. How you can prevent the shoulder dystocia? For the prevention of shoulder dystocia, you have to control the diabetes at the optimal level, like after 1 hour postprandial should be less than 140, and the fasting level should be less than 100. Optimal weight management during the pregnancy. If the patient is already obese, so too much weight gain is very dangerous for the patient as well. And third is the planned delivery, or you have to see whether the delivery is possible if the patient has the previous history of the shoulder dystocia. For that, you have to see the estimated fetal weight of the baby, and you have to do the pelvic assessment or the clinical pelvimetry is there any to rule out any cephalopelvic disproportion as well. Now, the how you will diagnose the shoulder dystocia? The diagnosis of the shoulder dystocia can be made when the head of the baby has been delivered. When the head of the baby has been delivered, and you can see this is the head of the baby of the delivered, but the shoulders are caught above the pubic symphysis, and the head is striking back over the maternal pubis. It is striking back against the maternal pubis. So that is called the turtle sign. As I can show you again, the head has been delivered. Because this is a dummy, so I can't like exactly show you the things. But head is already delivered, but the head is not head is retraction of the head against the maternal pelvis. That is the turtle sign. So this will confirm your diagnosis. And why this happens, the turtle sign? Because as I have already told you, there is the anterior shoulder is caught above the pubic symphysis, but it is due to the failure of restitution of the fetal head after the delivery of the fetal head. So all these you have to confirm the diagnosis of the shoulder dystocia. In every skill, I have already told you, there could be the certain prerequisite and certain contraindication. When you will go for your exam, you have to start every skill with after fulfilling all the prerequisites and ruling out all the contraindication. What could be the prerequisite for this delivery? There should be the senior help available. So call for help, number one. Number two, two obstetrical teams should be there. And these two obstetrical teams, one for the management and one for the resuscitation. For the management, two assistants for making the macrobid position, one for the suprapubic pressure, one for the documentation. Make sure the presence of pediatrician as well as anesthetist, because that could be ended into Zavinelli maneuvers where the cesarean section can be done for the safety of the baby. So call for help. Obstetrical team along with that of pediatrician and anesthetist. Bladder should be empty. Patient and relatives should be counseled. Adequate analgesia if there is an epidural, top of the analgesia. And if there is episiotomy, the episiotomy should be generous so the manipulation can be done. What could be the contraindications? The fundal pressure should be avoided, and too much traction should be avoided, because undue traction can end up in the fetal and the maternal morbidity. So What now I will tell you about the position. You have to flatten the delivery table. Foot head end should be as low as possible. The whole the delivery table should be flattened. The back of the table should be really flattened, so that the maternal back should also be flattened. All the footrest should be removed so that the manipulation can be done. After making this position and with all the teams, now you can perform the external maneuvers. What are the external maneuvers? First external maneuver is you can see macrobid position. In the macrobid position, you have to make the extreme flexion of the knee as well as the hip joint, and both the legs should be against the maternal abdomen, should touch the maternal abdomen. The benefit of this macrobid position, the sacral promontory will be flattened and the pubic symphysis will be rotated in the cephalic direction. So it will give you some space to deliver the shoulder. As you can see, the shoulder is caught, and the second, this shoulder is caught over the pubic symphysis. You can see from here. So what after making the macrobid position, the one, please come here, the one assistant which is doing the suprapubic pressure. The suprapubic pressure is also called the Rubin's one maneuver. So you can apply the suprapubic pressure like cardiopulmonary resuscitation. You have to make this position and apply the continuous rocking motion to release the shoulder below the pubic symphysis. This movement should be like the rocking motion in the downward direction, so that the shoulder can be displaced and the baby can be delivered easily. This is called the suprapubic pressure. Along with that, when the assistant is applying the suprapubic pressure, the one assistant should have the gentle downward traction. Along with that of macrobid, suprapubic pressure, and downward traction, 90% of the babies by deliver these three external maneuvers. When the baby is not delivered by these maneuvers, you have to go for internal maneuvers. First, one thing I forgot to tell, that there is a mnemonic which is called helper. Helper is a standard abbreviation for the shoulder dystocia, so that you can remember the sequence of events which can be done, the sequence of events or the sequence of the maneuvers you can perform for the shoulder dystocia. So, helper H for call for help, E for evaluation for episiotomy, L for the macrobid position or the elevation of the legs, and other E for entry maneuvers, R for delivery rotation of the posterior arm, and next R is all four position in a rollover position. So this mnemonic will help you to sequence your maneuvers, and you can remember with the help of this mnemonic. After the macrobid suprapubic pressure and downward traction, now I will do the Rubens 2. How you can perform the Rubens 2 maneuver? You have to introduce your finger along with that of the posterior lateral wall of the vagina, or you can go down the vagina along the posterior surface of the vagina, where you can go, as you can see from here, I can go and will reach the shoulders. You have to put your two fingers, if I can show you, you have to put your two fingers posterior aspect of interior shoulder and try to disimpact the shoulder in the that called the Rubin 2 maneuver. Okay? Along with this Rubin 2 maneuver, you have to perform the wood screw maneuver if this maneuver is failed. In the reverse wood screw, the same Rubin 2, you have to you have to go through the posterior surface of the vagina and reach the posterior aspect of the shoulders and place the posterior aspect of the interior shoulder and interior aspect of the posterior shoulder. I can show you from the outside the dummy. I have placed my two fingers over the posterior aspect of the interior shoulder and interior aspect of the posterior shoulder. Then I can rotate the baby in this direction, in the anti-clockwise or the clockwise direction. This is called the Rubens 2 or wood screw. Now the reverse wood screw. Reverse wood screw is the, now you place the two finger on the posterior aspect of the posterior aspect of the posterior shoulder, and if the baby is here, and I will place my two fingers over here and I will apply the pressure, the shoulder, the interior shoulder can also be disimpacted. If I will show from here outside the dummy, you have to place the two fingers on the posterior aspect of the posterior shoulder and try to dislodge this shoulder or try to rotate this shoulder so that this anterior shoulder can also be disimpacted and baby can be in oblique direction and can be delivered easily. This is called the reverse wood screw manner. So I have told about the Rubens 1, Rubens 2, wood screw and reverse wood screw. Okay, the delivery, now the delivery of the posterior arm. The delivery of the posterior arm in the sequence can be done before the Rubens 2 and wood screw. As we all know, the posterior arm is in the hollow of the sacrum. the posterior arm should be over the interior, should be knuckled interiorly, should be present interiorly. But sometimes this arm is present posterior to the baby. The arm can be present like that, but the arm should be in this position. When the shoulder is caught above, you can go from the posterior surface of the vagina and hold the arm of the baby. I'm just showing inside the dummy. Please come over here, and you can remove the arm. If I show outside the dummy, if this arm is like that, so you have to pass through the posterior surface of the vagina and hold the arm, flex the elbow, and remove the arm over the interior of the chest of the baby. So when the arm is, this posterior arm is delivered, there is enough space for the baby, that for the anterior shoulder that has been caught above the pubic symphysis, to move inside the pelvis, and the baby can be delivered easily. So this is the delivery of the posterior arm. Now all these maneuvers can be repeat on the all four position, that is called the Gaxing maneuvers.